everybody, my name is Ann Cooney and I'm a social worker with the Greater Philadelphia chapter of the ALS Association, and I'm here to speak with you today about what a multidisciplinary care team is and just some more information about what you can expect when you are going to be coming to clinic. So thank you so much for joining our symposium, and I hope that you find all of this helpful. First, I just want to say, what is a multidisciplinary team? This team is a group of healthcare workers from different backgrounds who also have different professional backgrounds. And we all come together and work as a team to treat complex medical issues, which in our case would be ALS. And this team works best together when all the members work towards a common goal and manage the symptoms of ALS and work towards maximizing the quality of life of our patients. So that is our primary approach and our goal. And I think even if I'm speaking a lot from the perspective of the Jefferson Weinberg ALS Center, but even if you attend a different clinic, I think you're going to find a lot of similarities in what we say today. So, I think it still kind of applies across the board. So who are the people that make up our team? We have a lot of players, and each one has a very important role with our clinic team. We start with our neurologist, and then we have a physiatrist, which is a doctor of rehab medicine. Then we have a pulmonologist and a palliative care physician. We also have a nurse practitioner, a respiratory therapist, a physical therapist, occupational therapist, and speech therapist, a certified medical assistant, a dedicated research team with a clinical research coordinator, and then part of the local chapter of the ALS Association. Those team members include an assistive technologist, social workers, and a mental health nurse. So all of these people work together as a team to provide the care that we offer to our patients at clinic. Kind of what you can expect when you go to clinic, and again, I'm kind of speaking from the Jefferson Weinberg ALS Center, but this is also, again, I think going to be very similar across the board. So prior to your visit, you'll be contacted by the program manager who will help schedule your clinic appointment, and then we'll let you know if there's any necessary paperwork that you would need to bring the day of your appointment. You're also going to be contacted by our nurse practitioner, who is going to ask a lot of questions to get a good understanding of how you're managing at home. And this information will allow the team to understand your level of function and where, if anywhere, you're struggling. So these areas can be really focused on when you come in for your visit. The day of your visit, you can expect to be at clinic probably 2 to 3 hours. It's a bit of a lengthy visit, but for all the disciplines to come and see you, it can take that long. Now, certainly it can be less, it can be more, but on average, we're going to say 2 to 3 hours. You're going to be in an exam room, and then one by one, the team members will come to see you. So you stay put, and we kind of come in and out. And of course, there's going to be times when you may not need to see every team member, and that's fine. And that can be determined prior to your visit or even the day of your visit. But I think many times our patients might end up seeing almost everybody, if not everybody, the day of their clinic visit. And the other thing, I guess, to keep in mind is, in between clinic visits is usually 2 to 3 months. So having that gap in time makes it even many times more imperative that all of the members do get to see you, because there's been a bit of time since we've seen you last. And if there have been changes, it's good to address those changes and then focus on what can be done. So that's what you can expect during your visit. And then post-visit, after you have left, the team, we all sit down at the end of that day and meet and discuss how your visit went, and each team member provides their assessment and then recommendations for any type of services, care, or support that you may need. Then what happens is the recommendations are written up, and then you would be contacted by our nurse practitioner, either by phone or email, to go over these recommendations, so you have a clear understanding of what is now going to happen moving forward from your clinic visit. Any services that need to be arranged, whether it be home care, durable medical equipment, community resource support services, chapter services, the appropriate team member would then have the responsibility of coordinating, arranging, ordering, making all of those things come together so you have the support that you need. If you have any questions, you can certainly, reach out to these team members, because we do, we don't just see you at clinic and then not talk to you again until the next clinic visit. Many times there is a lot of communication going on between clinic visits based on things that are happening, needs that you may have, and so forth. So there's always opportunity to talk with your team members in between clinic visits if that is needed, okay? So that's a kind of a good synopsis, I guess, of what you can expect when you are coming to clinic, in clinic, and after clinic. I hope that you enjoy the rest of the symposium today, and I hope you find it very informative. Okay, thanks.
I'm a certified medical assistant at Jefferson's ALS Center, the Weinberg ALS Center. My primary role and responsibility is to communicate between the patients and the care team, coordinate any of the patient's needs and the provider's needs as needed, refills, questions, confirming appointments. I do things like fill out disability forms, order forms, and scan the appropriate documents into the EMR system. And during clinic, I'm the primary person outside of the room organizing who goes into each room. Judy can go.
Okay. Should I go right away?
Mm-hmm.
Okay. Hi, my name is Judy Gore. I'm the nurse practitioner at the Jefferson and Weinberg ALS Center. And also, I also see myself mainly as a point of contact for patients, family, and the entire team, because essentially we work as a multidisciplinary team. And because I'm full-time with the center, patients would contact me directly, and then, I put them in touch with the appropriate people. Yeah, so I guess that's the essence of really everything, is the communication between the team members and the patient. And we've all been working together now for several years, so in most situations, we can deal with a wide variety of problems and issues. Thank you. Dr. Oliva?
Hello, my name is Kristalina Ilieva. I'm a neurologist with a neuromuscular disease subspecialty. I work together with Judy Guarneri and Chris Haig in the ALS Center. I was lucky to join and find a good team that was established before me coming to the center. My role is to meet the patients first, not in person, but through collection and review of the medical records that they have. Chris and Judy helped me assemble those, and then we review and evaluate those together. And at the time when the patient does come and we see them, we have an idea of what their journey has been up to that point. I evaluate the patient, examine the patient, and together we either confirm a diagnosis or ask for additional tests. My role in the center is, once the diagnosis is established, less prominent. I'm there to help with questions regarding medication, and I sometimes step back so that my colleagues in pulmonary care and physical therapy and nutrition can give the patient the support they need.
Hi, my name is Brittany Longnecker, and I am the respiratory therapist for the Jefferson ALS Weinberg Center, and I am here to go over the roles that I have during that clinic. The first thing that I do when a patient comes in at clinic is assess their pulmonary history. This includes any pulmonary diseases they may have, such as asthma, bronchitis, a history of pneumonia, if they are or were a smoker, if they take any breathing medications, or if they've ever had any surgeries on their chest that may inhibit their respiratory status. I also assess their current respiratory needs, so if they seem to be having any shortness of breath, if they're having any difficulty with clearing secretions, having a lot of oral secretions, and if they're having any difficulty sleeping. After assessing those things and talking with them, I then perform 2 breathing tests. The first one is a forced or slow vital capacity, which basically just measures the amount of air that they're able to blow out. To get this value, I take their age, height, gender, and ethnicity and put it into my spirometer, which is what they breathe through. And after they blow, it puts the value into a percent of predicted. Basically, we say anything greater than 80% of predicted is normal. Anything lower than that, we continue to monitor, but based off of their symptoms and how they're feeling is how we move forward with recommendations. The second test that we do is called a negative inspiratory force. And with this one, they suck in as hard as they can against resistance, and it gives us a value. And with that, it's indicative of their ability to cough. It basically measures their breathing muscle strength, so also a very important number. And then after we get all of the values, I provide education based off of things that I think they may need or may possibly need in the future. I think education is the best tool for these patients so they know what they can use to help themselves in the future. As well as going over the facts and things like that, I like to try and smile, have fun, and laugh, because people really tend to fixate and focus on these breathing numbers every time they come in for a visit, and it can be very stressful. So I try and ease their stress by just having a good time and being a more positive, optimistic person and presence in the room. Some of the common interventions and recommendations that I have for the clinic are a few things. The first one is a trilogy machine, which is basically a fancy BiPAP machine. A BiPAP machine is something that helps patients and people breathe a little bit easier. How it works are we set 2 levels of pressure. The first level of pressure is a lower one, and that just helps to open up the lungs and the airways. And the second level of pressure helps them to take a deeper breath in, hence the ventilation. So with a regular BiPAP machine, we have these 2 levels of pressure, and they stay set, the same thing, no matter what. With the trilogy machine, we set a volume that is specific for each patient. And with that volume, there are pressures that adjust constantly based off of the patient's needs. So if someone is sitting, laying flat, feeling short of breath, or breathing comfortably, the machine is going to sense that need and adjust the pressures with every 5 breaths. It really is an amazing machine for these patients, because one month they could be feeling a little bit better than the next month, and they may require a little bit pressure. So it's nice that the machine adapts to them. Another thing that's great about this machine is it has the ability to have a secondary mode set, what we call mouthpiece ventilation. With this, the machine is on standby all day, and if a patient feels short of breath, they can simply put a mouthpiece in their mouth, trigger the machine, and get 1 single breath. They can do this 1 time, they can do this 5 times, they can do this 10 times, as many times as they want until they feel comfortable. Another machine that we utilize a lot is something called a cough assist. And basically what this does is it mimics the motions of a cough. So if somebody's NIF that we talked about earlier is a little bit lower and they're having a hard time clearing secretions, I would recommend this because it's going to help to add a little bit more of a oomph to the patient's cough and help to clear secretions so they don't feel that like they have mucus stuck in their chest and they don't develop a pneumonia. So it's also very important. Another machine is an oral suction machine. It's basically a little vacuum that can suck out the patient's mouth if they're having a lot of oral secretions. And then another one is a nebulizer machine. This can be for a person who used to take inhalers, and because of having respiratory muscle weakness, they may not be able to get that big breath in to take the medication anymore. It's a little bit easier. Or if someone has a lot of wheeziness, chest tightness, it can help to get the medication in there, as well as a saline nebulizer can help to thin if they're having thick mucus. It can help to thin it out. Those are basically the most common recommendations that I have each week, and it helps our patients out a lot. I hope that this helps you to understand the importance of the respiratory therapist during the clinic. Thank you for tuning in, and stay safe during this time.
My name is Christopher Fico. My role in the ALS clinic is I'm a physiatrist, so I work as part of a group. We call ourselves the therapy group, but our role is really to focus on a patient's level of function and to help to figure out what their major issues are when we're seeing them, and to try to help them to problem solve those through adaptive devices and also through therapy training.
Hello, I'm Elisa Brownlee. I'm an assistive technology specialist with the ALS Association Greater Philadelphia chapter. And I am here with my colleagues, Dan Kelly, speech language pathologist from the Jefferson Weinberg ALS Center in Philadelphia, and Carol Freed, dietitian, nutritionist with the ALS Association Hershey Clinic in Hershey, Pennsylvania. And we are here to talk about how each of our disciplines interact as an interdisciplinary team in our various clinics. And I'm going to start off with Dan.
Thank you, Elisa. I'm Dan Kelly. I'm a speech language pathologist with the Jefferson ALS Clinic. I serve a variety of functions. Primarily what I do is I evaluate swallow function. That is to look at swallow dysfunction and optimize the function that individuals have. I look at swallow function and people's motor abilities on how it can impact their nutrition and their quality of life. We usually work through a lot of different methods to optimize quality of life for patients when it comes to eating. Also, we evaluate speech, voice, and communication to help facilitate communication. Back to you, Elisa.
Okay, and it will be Karen's turn, or Carol's turn.
Okay.
To tell you about the role of a nutritionist dietitian.
Okay, let me get this on. Okay. Okay, my role, basically, I will assess, first of all, any weight changes that the patient has had. And if there has been a weight change, such as the weight loss, which I see a lot of, we talk about what they're actually taking in now. We do a food recall, so I'll have them recall what they usually, what their typical diet is now. I'll assess for any appetite changes, their ability to chew and swallow foods, and if that's, affecting their intakes. Do they have access to food, the ability to feed themselves? And then common interventions will be calorie packing strategies. I have them weigh themselves weekly. Sometimes we have an issue with poor appetite. We can talk about an appetite stimulant or smaller, more frequent meals. We talk about tips for blenderizing foods if they need that, smoothie recipes. I often involve the family in making sure that they're available to chop foods or help with feedings. I find a lot that patients don't ask for help. So I have to make sure that the family is aware that they really do need to help if the patient needs it. Tips for relieving constipation issues, making sure they're hydrated, and then we discuss feeding tubes if that's appropriate at that time. Then I will go through and order the formula based on their needs, work with their insurance companies to make sure that they are getting that paid for. And it all depends. It's all, patient specific.
That's great. Thank you.
Mm-hmm.
And then I am going to talk to you about my role at clinic. As an assistive technologist, I work with almost every discipline because by definition, assistive technology is any piece of equipment, an item, software, or product that is used to increase, maintain, or improve the functional capabilities of persons with disabilities. So with ALS, you get a broad spectrum of people that need various forms of assistive technology, depending on the issue that they're having. So I work with the speech pathologists on communication devices, on amplifiers. I work with physical and occupational therapists to help individuals with ALS get wheelchairs or to access their computers or to create a smart home or utilize the remote control on the television. I work with the social workers regarding insurance issues. Sometimes there are psychosocial issues, especially when it comes to the acceptance of use of technology. And then on pulmonologists, because you need a way to call for help if you are using non-invasive ventilation, which you have a mask over your face, and how will you be able to call for help if you're doing that? So the importance of us all working together is that we want to provide interdisciplinary care because we are not obviously knowledgeable about all the different disciplines, but we also want to know that our people with ALS can optimize their care by tapping into services that Dan and Carol and the rest of the team offer, and that we work as a team. We are an interdisciplinary team. And if I go into a room and I identify a need, and I'll go into the hall and say to Dan, there's an issue and here's the issue. And then you, Dan, can address the issue when you do your assessment, same with Carol. So the three of us tend to focus on the muscles here and here. And so that's why oftentimes in an ALS clinic, you would see the three of us either together or sometimes just the two of us. Do you guys want to add anything else to your role at clinic?
I do work a lot with a speech therapist at my clinic. We actually see the patient together, which is good because a lot of the questions she asks, I'll need to know the answer to as well. So we're kind of a tag team. So it works out well.
Agreed. We work the same way. My dietitian's usually my sidekick. We go usually in a pretty linear order as far as weight loss, swallow function, then diet and nutritional needs.
Okay, great. So I want to thank the two of you for letting the audience know about what your roles are at clinic. And we will, in our second segment, move on to our case studies. Thank you.
Hi, this is Gail Hausman from the ALS Association Greater Philadelphia Chapter. I'm a nurse, and I've been working for the chapter for about 20 years now. I'm involved with the Jefferson ALS Clinic in Philadelphia, and I'm here to talk about the role of the mental health nurse at clinic. One of the first things I do when I meet with a person with ALS and their loved ones is just ask them how they're coping, and just try to get them to talk about that a little bit. It's very common for people with ALS and their loved ones to have some trouble coping with what they're dealing with. So that's what we talk about. My goal is to try to establish a connection with the patient and the family. So I've listed on my slide here some bullets, some of the issues that may or may not come up with the person with ALS and their loved ones. Some common interventions or suggestions from me, the message that grief is normal. So most people go through a grieving spell with this illness, and it may last for a while. And that's completely 100% normal. So the feelings, like for instance, feeling depressed is normal. Feeling angry is normal. Any of the feelings are normal. We talk about finding emotional support, like identifying people in their lives that may be of help. I might talk about attending a support group, or some sort of, perhaps getting some type of supportive therapy. I educate about psychotropic drugs, which are medications that are used to treat depression and anxiety. And occasionally people with ALS find those drugs helpful. I ask and I try to do something called ECAS testing. ECAS is the Edinburgh Cognitive Assessment Tool for ALS. And what most people don't realize with ALS is that about 50% of people with ALS have some cognitive impairment. It's usually a mild form of impairment. It may not even be something that they recognize or that their family recognizes. So what we do at the clinic is we do testing for this with a screening tool just to identify if there might be some problems with this. We only do it once. And I say we because Laura Oakley, who is our research person, and I do the testing. I might educate about disease progression for any questions. I do usually talk about living wills, medical power of attorneys, and advance directives. And I talk about how to complete an advance directive in a living will if the person is interested. I try to acknowledge and address caregiver issues or concerns. And we talk about quality of life for both the person with ALS and their loved ones. That's it, Tim.
Janie Eskovitz, and I'm a social worker with the ALS Association Greater Philadelphia chapter. I'm here today to talk a little bit about my role as a social worker. So look at this photograph here, and sometimes that's the way people look at me when I tell them I'm a social worker. At the Greater Philadelphia chapter, one of my other roles is also to have a presence at the ALS clinics and part of the multidisciplinary teams. When a patient is confirmed with an ALS diagnosis, or the neurologist has given the diagnosis, they are encouraged then to have the families register with our chapter. And when a patient and family are registered with our chapter, they then in turn are assigned a social worker. At that time, contact is made with the family. Family may give this kind of appearance. Why do I need a social worker? What is your role as a social worker? When I make initial contact with the family, you can imagine that this may be the first or second person after they've been diagnosed, that someone has really openly said to them, hey, I'm on this journey with you. Or, hey, you're not alone on this journey, and I'm going to help guide you. That's a sense of comfort for these individuals. And at that time, I try to do what I call a psychosocial assessment. And what that exactly is it is a way in which I can engage families and the patient to find out a little bit about who they are. Because ALS does not define who you are. You are a person before ALS. What kind of hobbies, what kind of enjoyment did you have before all of this? What kind of work do you do? Or did you do? Are you married? Do you live alone? Do you take care of a disabled child? Do you take care of your older elderly parents? What type of home do you live in? Is it a 2-story home? Is the main bedroom and bathroom on the 2nd floor? What are some of the challenges that you're gonna have at your house in terms of accessing things? Are you connected with your community? What are your informal supports? Do you have good support from your neighbors? Do your children live nearby? Are you connected with your church? All of this information gives me a clearer picture of who this person is, what are their strengths, how are they coping, and then it allows me then to assist and identify goals that we can achieve with this family and moving forward, as well as sharing this information with the rest of the multidisciplinary team. So I'm going to assist the patient and family in resource planning. If somebody is working and they're no longer able to sustain the job, how are they going to function at home? What kind of insurance are they going to have, if any? Is their loved one going to be available to assist them during the day? As the disease progresses, so may their needs. And so may it need a social worker to maintain contact with the family in developing a safe care plan as their needs and care needs are identified. Another important role of a social worker is to assist the patient and family with financial counseling. If somebody was working, do they know if their employer is providing them with short-term and long-term disability? Do they know what their health coverage is? Do they know that if their health coverage offers any type of insurance coverage for durable medical equipment? Do you know what durable medical equipment is? Is the individual a veteran? And if they are, then we want to connect them with the Veterans Association. Does the individual have a long-term care policy? And if they do they know how to access that policy? And does that policy have paperwork that needs to be initiated? Does that policy enable them to have some type of home modifications? Is their loved one employed? Can they go under their loved one's employer health coverage? And if someone is not going to be returning back to the workforce, has that individual explored eligibility for Medicare? We know that individuals that have worked enough work units per lifetime and have paid into the government, they may be entitled to access Medicare and Social Security disability within a 6-month period. But what happens during that 6-month period if you're no longer getting your insurance or finances? These are things that you need to really explore, and I want to help families, educate them, and empower families to figure this out and to try and find out so that they can make educated decisions. And then we can work together in accessing the supports and resources that they need. Oftentimes, we will see families at the ALS clinics, but sometimes there's not enough time to really discuss very sensitive issues, or perhaps the individual and loved ones are getting anxious and it's not the time to bring up certain issues. It may be indicated at that time that perhaps we might want to schedule a home visit where we can come to the client's home and address different needs that might not be able to be addressed in the setting or in a hospital setting. Also try to collaborate with the other staff and clinic team members to let you know how the patients are feeling, what their desire is in terms of staying in their own home, what their feelings are about managing on a first floor. So we want to collaborate with the staff and the clinic team members, as well as identifying what resources are available at the ALS Association that might be able to help these families, and collaborating with the PT to see if our ramping or if our stair glide program is something that we can look into, or perhaps maybe a caregiver needs some respite help in the home. We know with the ALS is a disease that is a progressive one. So we know that end-of-life decisions may have to be broached with the families. This is not something that we are always accustomed or that we are comfortable in talking, but talking with families about advanced directives and living wills is very important at the very early stages in educating families about what their end-of-life decisions are. Does a family perhaps want a trach or a vent? Perhaps they don't know what this is. So educating families, giving the tools and the resources so that they can make good decisions. Patient advocacy. Many of us at the ALS Association Greater Philadelphia chapter are very involved in advocacy, both at a local, state, and federal level. Frequently, we are asked to engage some of our patients that might be interested in attending some of these events at Harrisburg or perhaps in Washington, giving patients a voice, letting their voice be heard, going to Capitol Hill and talking about the impact of the disease, the impact of the insurance or lack of, the impact that a 6-month waiting period may have on them and their loved ones. This may be something that for some individuals might be a very powerful way for them to give back. So we're very active in doing this at all different levels. The ALS Association has 13 support groups so that individuals in different communities may be available to them to partake in, because we know that it's very useful for individuals to be around other people that are going through a similar experience. And I facilitate an online support group for caregivers, because the role of a caregiver and the role of a patient may be very different. And isn't it going to be helpful for you to be amongst other people that are going through a similar journey? And then we also, as social workers, try, as I've mentioned throughout this, to connect them with the many programs and supports that our chapter provides, such as respite programs, transport programs. Sometimes individuals are not able to get to the clinic as their care needs are increasing. They may have a power wheelchair, which they're no longer able to access into their car. So how are they going to come to a clinic? So the ALS Association has a wealth of resources that your social worker can educate you about and connect you with as the needs arise. Thank you very much.
Hello, my name is Dr. Maggie Crayer. I'm an associate professor of family and community medicine in the Division of Geriatrics and Palliative Care here at Jefferson University. My role today is to describe how a palliative care specialist interfaces in the multidisciplinary team in the care of patients in the ALS clinic. Palliative care is specialized care for people living with serious illness. We focus on the assessment of symptoms, the stressors of illness, and provide an added layer of support to patients and families. We collaborate with multidisciplinary ALS team members to address key symptoms and sources of distress. We support complex medical decisions that patients and families face during the course of ALS. Our goal is to match care that is consistent with the patient's wishes and goals. We help patients manage symptoms and keep control over their medical decisions and maximizing quality of life. For instance, we assist in identifying the most troublesome symptoms. We identify patient and family sources of distress. We assist in the pros and cons of medical interventions in those discussions surrounding feeding tubes, breathing machines, and medications. We help patients focus on what is important in the moment and what is important over time. We support patients' decision-making and support patients in advanced care planning. We collaborate with the multidisciplinary team consisting of the neurologist, the pulmonologist, physiatrist, mental health nurse, social workers, technology specialists, speech, nutrition, physical and occupational therapists to implement treatments and interventions consistent with patient goals and views on quality of life. Okay.
My name is Laura Oakley, and I am the clinic's clinical research coordinator. And my role within the clinic is to really educate patients about research and the importance of research, and to enroll them in clinical trials if they have an interest.
Hello, my name is Pira Pasinelli. I'm a professor in neuroscience at Thomas Jefferson University, and I'm the director of the Weinberg ALS Center at Jefferson. The Weinberg ALS Center, which is a clinical and research integrated program that comprises of a multidisciplinary clinic, like this panel really shows, 4 research laboratories working all together on different aspects of the complicated heterogeneous pathogenesis of ALS, and the clinical research program that Laura will describe. So normally what I do in clinic is really to wear 2 hats. One is really to enable the patient and our clinical staff, like our center staff, to really cater to the needs of every single patient, which are, as we always say, immediate needs for a symptomatic treatment and ultimate needs to find effective therapy. And then I also wear the second hat as a researcher to really educate the patient on the landscape of research in general, ALS research in general, the state of the art of ALS research. And although today really we are gonna talk about a scenario in clinic, and Laura and I will recreate 2 scenarios of us meeting patients in a clinical setting, what the research does in the context of a clinical research integrated program goes really beyond the clinic visit. We maintain a relationship with the patients throughout, in between clinic visits. We have, across the street from the clinic, 4 laboratories where we host at least 2 or 3 times a year open houses for the public, where we really invite the public in to show them how we work and to engage the patients and the community into our research. And our doors are always open. Why? Because we strongly believe that as much as a patient and the community needs the research to identify effective treatment and eventually a cure for this disease, the researcher needs the patient as much as the patients need us. Because good translational research and good research geared towards finding effective treatment starts with the patient and ends with the patient. And we strongly believe that an educated patient is a happy patient.